But in terms of systemic therapy, I think that we try to separate out endocrine therapy, chemotherapy, and biologic agents. We will be discussing this further in future slides. But there is also radiation for certain patients with certain needs. So for example, if someone has brain metastasis or bone metastasis, radiation can be used to, number one, relieve pain, number two, prevent further symptoms, and number three, stabilize that particular area. Surgery can also be used to stabilize the metastasis if it is a metastasis to the bone and prevent any problems with future fractures. So yes, this talk will be concentrating more about systemic therapy and the side effects in systemic therapy, but know that we as your healthcare providers will always be looking for other modalities to try to treat your cancer symptoms or your cancer problem. So first with endocrine therapy, I think that as an oncologist, when you go see them, that there are many kinds of treatments in terms of pills. It goes back to what your cancer is susceptible to. So there are patients with what we call estrogen receptor positive cancers, and there are patients with estrogen negative cancer. So it is only the people with estrogen positive cancers that we can treat with this endocrine therapy. Thankfully, most patients diagnosed with breast cancer will be estrogen receptor positive. So in this essence, that something as simple as a pill, 1 tablet a day, may be enough to control the cancer for years. At the same time, if patients progress on one medicine, or if they have side effects on one medicine, we can switch to another medication and try to get the same control without the same amount of side effects. There is also what we call fulvestrant or Faslodex, which is a shot form of the medication, to also give estrogen receptor positive patients control of their disease. Of course, with endocrine therapy, it is different from the common chemotherapy that most people think about. Most people will think about hair loss, nausea, vomiting, and the feeling of extreme fatigue. That is not the case with the pill medications, that most of the time it is much better tolerated, and that really nobody would know that people were on any kind of treatment at all. Then we have the biologic agents, which are what we call more target therapy. So for our breast cancer patients, we have patients that have certain receptors that are being expressed. So in over a third of patients, they express what we call HER2 new receptor. So we have a targeted therapy to target this particular receptor and block it and essentially try to control the disease better. So some patients may have this particular treatment in their armamentarium. Some of these treatments are intravenous, and some of these treatments are pill form. So finally, to our cytotoxic chemotherapy. This is a slide from our National Cancer Network, and as you can see, there are many cytotoxic chemotherapies that can be offered to our patients. And the choice of the chemotherapy really goes back to, number one, what is the chemotherapy that is going to help the patient the most with the least amount of side effects? Because we always want the most amount of benefit with the least amount of side effects. So it may go back to number one, if the patient was previously treated with chemotherapy. Number two, what kind of other health problems the patient may have, because some of these chemotherapies require other medications, such as dexamethasone, which is a steroid. For example, if your loved one has diabetes, we may not want to use any chemotherapies that require dexamethasone to be used to prevent any increase in blood sugar. So again, there are many different chemotherapy options, and the option that we pick for your loved one really goes back to, number one, what we feel will help the patient the most. Number 2, what the patient will tolerate. And number 3, what other health problems may they have that may limit the kind of choices that we choose. So to the most common chemotherapy side effects. When our patients come to see us, we review the chemotherapies, and sometimes I think that they smile and they say the side effects of the chemotherapy, of the treatment, seem worse than the side effects of the cancer itself. And of course, we always want to see that, our patients are as educated as possible about the possible side effects, but at the same time that they're not experiencing every single side effect. The only way to know that is to try the chemotherapy and see how they tolerate this. But in general, the side effects that are often experienced is what we call chemotherapy, nausea, and vomiting, hair loss, fatigue, Chemobrain, Mucositis, Osteoporosis, low blood counts, and infection. We'll be reviewing these later to review what kinds of things we do or interventions to decrease these side effects. Now, the intensity or the level of these side effects are variable, and depending on some patients, they may not have very severe side effects to mandate or to require further treatment. But we always tell patients about these potential side effects. So over time, from the 1980s to the 1990s, the most common concerns of patients from the chemotherapy that is the most distressing is really going back to chemotherapy-induced nausea, vomiting. So in the 1980s, it was more of a concern of vomiting. In the 1990s, we've had new drugs called the 5-HT3 blockers to help with nausea, vomiting caused by chemotherapy. Unfortunately, it seems to be more effective with vomiting than nausea. So in the 1990s, in essence, still nausea is a quite common theme from our chemotherapy. But it is important to note that nausea can also come from other reasons, such as, number 1, the cancer itself, which is releasing chemicals into the blood that make the patient sense this feeling of nausea or this feeling of not wanting to eat. And secondly, the patient may have nausea if they are constipated, meaning that they're not able to move their bowels. So for chemotherapy-induced nausea, vomiting, as you can see that there are many, many pathways that can cause nausea. So this picture really shows nausea from pathways that we are aware of, but obviously we know that there is continuing studies and continuing areas where we're trying to define and better control this nausea. But as you see, each pathway, either through dopamine, serotonin, acetylcholine, histamine, and substance P, is an area where we have had a particular medication to try to block this pathway and to try to improve nausea. Most patients after chemotherapy will have nausea, vomiting for approximately 5 days. And usually the nausea, vomiting should subside after the 5 days. The most acute period is the first 24 hours, and usually it should improve over the 2 to 5 days after chemotherapy. There are various medications that we use to prevent chemotherapy-induced nausea, vomiting, and it is important to note that your physician or your healthcare provider will try to see how much control your loved one needs in terms of this particular symptom. Because we always want to try to see what is the least amount of medication that someone may need to make sure that there is no added side effect and no additional problem. But it is important to know that there are many, many nausea, vomiting medications out there. Of course, there are other non-pharmacologic ways of managing nausea, vomiting. I think that for a lot of my patients, I encourage other ways of treatment, and it really depends on what kind of modalities they would like to try. I think that there have been a lot of studies on having relaxation therapy with aromatherapy, and perhaps other kinds of treatments such as acupuncture. Now, with any of these modalities, it is very difficult to have a very good randomized controlled trial to really evaluate the true effectiveness of these modalities. But I believe that, most of the time with these modalities, they have had small groups and small patient populations that have benefited. And if it is something that the patient is willing to try, it is something that I do encourage. There are other studies that have looked at, for example, ginger and flavonoids. So in the ginger studies, there have been small studies that seem to indicate that there is some benefit for patients for nausea and vomiting. Now, of course, this is usually used in conjunction with our conventional therapy. So in this particular study, women were randomized to 1.5 grams of ginger that was divided over 3 doses for 4 days after their chemotherapy. And it was found that most of the patients had improved nausea with the addition of granisetron, which is a 5-HT3 blocker, during their chemotherapy period. The only problem is that if this was an open-label study. Open label means that the patient knew that they were taking ginger. So ultimately, the study is flawed because there is what we call the placebo effect. There are times when, if the patient knows that they are on a particular ingredient, that just knowing that they are on this ingredient and believing that they will work will help the patient. So there are studies to confirm that there is benefit to ginger, but these studies are not great, and some of them are conflicting. But usually most of my patients, when I talk to them, if they're willing to try some other things, I tell them about the ginger. At the same time, there are other things, such as flavonoids, that people can take. I think that flavonoids are put into particular supplements, but I usually try to encourage them in natural foods, things that can be found naturally without being processed. So there actually was a study with Concord grape juice that they gave the patients 4 ounces of this grape juice compared to placebo. And this particular study was interesting in that they actually had taste testers taste the artificial juice versus the actual Concord juice to make sure that the patients would not be able to have a distinction between the actual Concord grape juice versus the juice that was just artificial coloring and citric acid without any of the flavonoids. And what they were able to find was that the frequency and severity and the distress of the chemotherapy nausea vomiting was decreased significantly. But of course, the problem of the study was that it was small. It was not large enough to say that the results were what we call statistically significant. But nonetheless, there was a positive association. Then there is the issue in terms of side effects of this question of Chemobrain. This is an entity that we continue to look at. We actually have an ongoing study that we are participating in to evaluate the effects of Chemobrain on mathematical skills, on mentation, and also on computer skills. But Chemobrain is felt to affect approximately 1/3 of our patients and may last for months to years. What it can cause is impaired attention, memory, and visual spatial function. So for a lot of patients, they just may feel that they're not quite themselves, that they may have word finding difficulty finding thoughts and mental tasks, and that Chemobrain is not necessarily affected by other factors such as menopause, depression, or low blood counts during the chemotherapy itself. So they try to evaluate, this is the first longitudinal controlled study of patients undergoing chemotherapy, to see if there was actually a strong correlation with the chemotherapy and this mental slowing. And that is why I say that there are sort of conflicting reports in terms of how much change in your mentation does the chemotherapy cause. And in this particular study, they were not able to find that there was a clear correlation with the chemotherapy and with the actual patient's functioning. That the only thing that was affected was the motor skills. That they felt that the chemotherapy did slow the motor skills, most likely because of the side effects from the chemotherapy. But ongoing study on Chemobrain will hopefully give us more information. So I usually will recommend general things for our patients, and many cancer societies and many organizations also give our patients tools to try to cope with this potential problem. I think that with most of our patients, that we always encourage them to write things down, especially when they come to visit us, because sometimes they may say, well, Dr. Chang, I forgot what I was going to say to you, earlier. And I always tell people, well, if you forget and you remember again, you write it down, and then, when I call you, we'll have another conversation. So I think that trying to have, a daily planner, putting things down is very important. Also, just like we encourage physical exercise, I think that we should also encourage mental exercise. And whether or not it be things that you like to do with word puzzles, or trying to extend your vocabulary, or just playing a musical instrument is very stimulating to your brain. I think that having good sleep and resting your brain well and keeping your body in shape is very important, along with having foods that will actually give your brain, the adequate nutrients that it needs, specifically omega-3 fatty acids, which I usually would recommend in food, because I think that there are so many foods that already have the omega-3 fatty acids, such as the salmon and the sardines and the fish in general. And of course, there are things that, people can do to try to, work around their schedule, and at the same time, try to, allow, their work habits, or, also to their friends, to know that they're going through some treatment, and that perhaps during that time, they will not necessarily be as sharp or as focused as usual. Now, I mentioned Chemobrain as a side effect of the chemotherapy, but of course, I think that it is important as a caregiver and someone who knows the patient the best and sees the patient, more than the healthcare provider, more than anyone else, is to say that if truly the patient is changing, that it is important to bring it to the attention of the healthcare provider. Of course, it may be the side effect of the chemotherapy, but we always want to make sure that it is not such a significant change that may mean that it's possibly from the disease. Then there is fatigue. I think that fatigue is very difficult to treat, that we don't have a vitamin to give energy necessarily. I think that for a lot of patients, even though it's counterintuitive, because if they feel tired, they feel, how will I be able to do any exercise? But in essence, that, the actual physical activity can actually make or help someone feel less fatigued. And when we talk about exercise, it is not a marathon. We're just talking about light exercise, such as a walk, or whatever the patient can work themselves up to. And this can actually let them feel more rested and more energetic. And at the same time, the most important thing for them to, also understand is that you can lose muscle and fat, during the chemotherapy process. So it is important to, maintain your exercise so that you can maintain your muscle tone. So I think that nutrition is a very important aspect, and I usually refer most of my patients to a nutritionist. I think that with most cancer centers or most offices, they should have a nutritionist available to review with the patient what they can do to, number one, prevent, a vitamin or a nutritional problem during the chemotherapy period. Number two, to maintain a healthy weight. So a healthy weight meaning the patient is not losing too much weight, and at the same time, the patient is not gaining too much weight. So generally, when patients are going through chemotherapy, that sometimes they may not be able to tolerate large amounts of food because of the nausea. So most of the time, we would recommend that they eat smaller meals a day. And ultimately, the largest meal should be when they are hungriest. And it may not necessarily mean at night. It may mean the midday. Also, to have high-protein foods. A lot of patients have asked me about juicing, and I do tell them that, juicing definitely allows them to get the calories and the vitamins that they need without necessarily making them feel too full. I think that also there are good supplements out there, Ensure and Glucerna, to help patients maintain their calorie and protein intake. Now, I just named those particular supplements, but it can be any brand. And some people find that they don't like the thickness or the sugar from some supplements, and that they can find other powder supplements that have the same amount of nutritional value without the sugar. And of course, again, I think that being as active as possible, drinking as much fluids and hydrating the body well is going to be very important. During the chemotherapy process, some of my patients may feel more fatigued, especially around the chemotherapy period, meaning the first few days after the chemotherapy. So it may be very helpful to have the food purchased before the chemotherapy, or to actually have your loved one or caregiver be able to purchase the food for you. I think that our nutritionist, is always there to help. And most of our patients, if we, see that there is a problem with weight loss, that we will try to make sure that we have the help of, our nutritionist, and at the same time the help of the caregiver to see what kinds of foods that they may like. Now, the chemotherapy can sometimes cause a taste disturbance, meaning that some patients may feel that they taste metal, or that there's a bitter taste, or that they've lost the taste of food. And there are other foods that they may never have thought of trying that they may, be able to tolerate more or better during the chemotherapy period. So I always, ask them to sort of say, well, if it is a certain food that you don't like, then try something else. And I think that our nutritionist usually tries to give some selection, such as the avocados, the nuts, and the seeds. But again, I think that it is very important to review with your healthcare physician and also with the nutritionist. I think that one of the barriers to proper nutrition, other than having a taste disturbance, is what we call mucositis. That it is a common problem from chemotherapy, and it can be, quite a problem during the chemotherapy period. That it can affect the chewing and swallowing of food, and if you're having a lot of pain, the patient is not going to be able to eat. So to understand mucositis, that it's important to understand that the chemotherapy is not only killing the good cells, the bad cells, that some of the good cells will be a victim during this time. The good cells, meaning some of the lining that covers the mouth, the esophagus, or the stomach. And what happens over time is that, yes, it will get denuded with the chemotherapy, but that there will be regeneration. That this regeneration will usually occur 2 weeks after the chemotherapy. Now, the definition of mucositis has changed over time, and I think that the most important thing to get out of this is that it can be quite debilitating. The risk factors we usually look at are patients with poor oral hygiene, poor nutrition, and of course people who already have tobacco and alcohol use. That if we see this from the beginning, that we will try to do interventions such as having them start with a biotin, a mouthwash, also trying to have them curtail their alcohol use before the initiation of chemotherapy. When we see problems with their kidney and liver function, adjustments to their chemotherapy doses will be made. But of course, the liver is very important to process the treatments or any medications that go through the body. So understandably, if the patient has problems with their liver function, they will have a little bit more toxicity associated with the chemotherapy treatment. So as treatment for the mucositis, that there are different topical oral rinses that we have available for our patients, such as the Magic Mouthwash, the Cafazole, and the Gel Clear. And these are all topical rinses that does not have to be swallowed. That is, something that we swish in our mouth and we spit out, and allow the patient to have comfort and relief until the mouth heals up. Sometimes people can develop an infection in their mouth and will require antibiotics. For patients where the pain is debilitating or really truly preventing them from eating, they may need oral or intravenous pain medications at that time. The next most common side effect is osteoporosis. And some patients may say, well, if I have metastatic disease, how is osteoporosis really going to affect me? And it's important to understand that osteoporosis did not start, bone loss did not start when you started the chemotherapy. The bone loss has started when we were much younger. That once we, left our 20s, that the bone is no longer continuing to build up. That we are actually losing bone year after year. We're also losing bone with our diet, which most people, if you were to, ask how many servings of calcium-laden foods do you have, most people are not able to say at least 5. At the same time, pregnancy and childbirth also puts our calcium stores at a lower level. So when patients go through our chemotherapy with their, their baseline calcium and bone reserves, that the osteoporosis or bone loss can occur a little bit more rapidly because the chemotherapy may bring the women into earlier menopause, and this will accelerate the bone loss or osteopenia. And to prevent this, we recommend dietary calcium and vitamin D. That a lot of times, again, we will try to see if the patient can get it naturally through the food, but if not, then it will have to be through a supplement. To maintain the bone mass, that it is also important to, again, have exercise, especially weight-bearing exercise, to help maintain the bone. Alcohol consumption and smoking are never good things, but I think that it's important to make sure that we limit alcohol to 1 glass a day, if any. And there are other medications to try to strengthen the bone. Now, your doctor, depending on what kind of metastatic disease that you have, may already have you on a special medication to protect your bones. So it's important to note what kind of medicines you're on to help the bones. Another problem that we see, with our chemotherapy patients is that there can be the problem with weight gain. So during the chemotherapy, some people may gain weight and some people may lose weight. But with the endocrine therapy, which is the tamoxifen, the aromatase inhibitors that we had looked at previously, that some people may gain weight. And it is important to note that weight gain, is something that can occur over time. And it may just be a few pounds a year, but over time it really does add to, how your body's going to handle glucose or sugar. It adds to how you're going to look at yourself in terms of your body image. It also may affect if you've had surgery to the arm, lymphedema, and it may actually decrease the benefit that you have gotten from the chemotherapy or from your treatment. Because what happens is that with body fat, the body fat is where peripheral estrogen is made. And with more estrogen, some patients, what the theory is that you may have, competing mechanisms for cancer growth. That if you have a high BMI, that it is cancer risk, and also that it may decrease the effects that you got from your chemotherapy, decrease the benefits, I should say, from the chemotherapy. So as a corollary to nutrition and to maintaining a healthy weight is a question that I get asked commonly, that a lot of patients want to know if there's a supplement that they can have to fight cancer. If you were to look at the compendium or even look at the web, there are hundreds and hundreds of supplements out there, and it's truly a billion-dollar business. But if you were to review the literature, and this is from Dr. Frankel, about the 10 supplements with the most amount of literature for cancer fighting, that you will see that it is these 10. Now, the problem with these supplements, with any of these studies, is that it is not FDA regulated. And at the same time, the studies that have been done, some of them are conflicting. And they are usually of a small sample size, meaning that there's only been a handful of patients, namely maybe 100 patients that have gone through the study. Now, I have picked vitamin D, which I think that it is found quite often in the news, and I thought that would be the least controversial of all the supplements. And even within the story, there is controversy. So in the last American Society of Clinical Oncology meeting, there was a review of past studies that were done on vitamin D levels and its association with breast cancer survival. That it was felt that if you had a low level defined as any vitamin D level less than 14 to 30, that it was truly associated with worse survival. And the mechanism or the reason for this is still under evaluation. But at the same time, there have been other studies, such as the Nurses Health Initiative, and this is an initiative evaluating over approximately, thousands of women since the 1980s, 1990s, that they did not show any correlation with vitamin D levels and breast cancer risk. So what I tell patients is that vitamin D is very important for maintaining bone health, that the goal is to try to keep the vitamin D at a normal level, which is a little, around 30, and that there may be some benefits, additional benefits from the vitamin D, although this is controversial. Again, this is just showing that there are other natural sources of vitamin D. I think that in this particular area that we live in, it is very difficult to get an adequate amount of sunshine to have a good level of vitamin D. Therefore, a lot of patients, if they cannot get it, naturally, they try to get it in the form of supplements. But vitamin D does come in some of the foods that we eat. So, in terms of the next step, which is social network or social support, I think that it's very important for our patients to have a good relationship with not only their spouse, but other, friends, and also to have good relationship in their community and also, amongst their, if they volunteer or if they attend church. The reason being is that it is known that the stronger the social relationship, that perhaps that there is better survival and quality of life with the breast cancer diagnosis. That the correlation or the reasoning for this is felt that perhaps the patients are more integrated into the community, that there may be less depression, that they may have more help to actually go to the doctor's office, to actually have help with the food, that at that point they are able to fight the cancer and manage the cancer better. I think that, depression is something that we always look for in our patients. And it is also something that the caregiver can be attentive to because you will be seeing your loved one more than we are. I think that it is important because mortality has been associated, increased mortality has been associated with people expressing either depressive symptoms, just being sad, versus people who fulfill the criteria for major depression. Now, your physician would, once they're alerted that the patient may be depressed, would be the one who talks with the patient and makes the diagnosis. But it's important to try to see if there's depression, number one, how we can improve their quality of life, and number two, how we can make their diagnosis or their symptoms better. So in one particular study, they evaluated patients over the course of 1 year with what we call a survey, and this is a depression symptom survey. And they found that people with decreasing depression, meaning that they may have been depressed initially, but over time that they were able to improve in terms of their symptoms, they'd lived on average or median 23 months longer than patients who had worsening depression. Now, of course, it is difficult to say whether or not the depression was closely related to whether or not the patient achieved control over the disease, or was it, more of, the fact that whether or not the patient had control, that they were able to, because the depression was controlled, deal with, what was happening, and at the same time be able to get the treatments that they needed. There are also quality of life, issues that people continue to look at. So most of the time, we have, our patients, come in and we talk to them about, how they're feeling. And there are certain questions that we try to field. And, obviously in this particular study, they tried to see how integrated the patient was in terms of their, their community and also in terms of their family support. I think that what is interesting from this particular study in terms of quality of life is that they found that people with positive social support networks had lower levels of nausea, pain, and did not need as much bed rest, and also had higher levels of energy. At the same time, the quality of life was higher for patients who had a very high social interaction and high amount of support. And these are all very good things. And this is without any medications or any pharmacologic intervention or anything else. The interesting point also was that the quality of life was slightly lower for patients with high amounts of affection. And the speculation was that, even for patients who had a lot of love in their life, that perhaps they felt a lot of pressure to, always have, to feel fine or to look fine for their loved one, versus people who just had a very high social interaction, that they were able to, be truthful about what was going on, and that they did not have to maintain a brave face. Now, this is speculation, and this is what the study found, but this is what I tell my patients when they see me, that most of the time they are very lucky to have wonderful caregivers, wonderful families, wonderful support groups. But I do mention that sometimes they may be open to, other support services and potentially have either a volunteer or have a social worker talk with them, because in that particular instance, it is counterintuitive, but it may be easier to be honest with a stranger than to be honest with your loved one, because I think that, the patient with cancer, if they're not feeling well, they may not want to tell their caregiver and concern or worry their caregiver, versus it is easier to tell a stranger and just, be able to confide in them. And we will talk with the last slide regarding different kinds of agencies that are, or different kinds of places that people can reach out to. So as a tool, because I think that, obviously the caregiver or the patient can alert the healthcare provider about any emotional problems, but as a tool, I think that, this is the National Comprehensive Cancer Network. This is, something that patients can print out, that this is actually in the patient section of this particular network. So people can go, that you can go online and you can get this a tool to, number one, have your loved one fill out, so that when you give it to the physician, your physician can be aware of any problems, or any issues that need to be addressed, either with social work, with counseling, or with some, adjustments to their treatment. And lastly, about the cancer pain, I think that it is truly a very, very important symptom, and over 50% of our patients experience pain. I think that it is important to look at underlying causes, that it may be because of the cancer, but we always have to make sure it's not from something else. For example, that is not because of side effect of a medication, such as the aromatase inhibitors. So part of the endocrine therapy that we have to treat estrogen receptor positive breast cancer patients are pill medications called anastrozole and letrozole. These medications can cause in up to 1/3 of patients what we call arthralgias or bone pain. And in some of these patients, the bone pain can be quite debilitating. So it is necessary to understand that these medications can be stopped, they can be switched, and that the side effect can be improved, and that the patient does not have to live with this kind of pain. If the pain is because of the cancer, of course, the first step is to try a non-opioid medication first. There are some medications that are very effective for people with metastatic bone pain, such as anti-inflammatories, dexamethasone, and the non-steroidal anti-inflammatory medication. So your doctor will usually try to adjust your medication and try to help you with that particular aspect. There is also, again, the option of palliative radiation, depending on where the pain is. That potentially you can see the radiation oncologist and have what we call a spot treatment, meaning a treatment to that particular area of the bone that is bothering you the most. And if necessary, patients will use what we call opioid medications. I think that for the general public who is not used to being sick and has not really used any medications, there is a stigma to using pain medications, and I don't think that there should be. I think that if the patient has tried other forms of pain management, and if the patient does not have adequate control, it is very important to be able to say that there are other opioid medications, either oxycodone or hydrocodone or hydromorphone, that may improve the patient's pain, quality of life, and functioning. So I think that for a lot of patients, number one, they have the barrier, the concern that, oh, they're going to get addicted to the pain medication, which in a lot of studies has not been true, that if the patient is using the medication appropriately, meaning for cancer pain instead of for other reasons, that it is, not going to cause this kind of problem. So when we evaluate our patients, I always encourage them to have a way of expressing how they're feeling. I think that one of the tools that you can bring to your doctor, or you can bring a diary, is what we call a pain scale. So this just happens to be the Wong-Baker faces that really allow you to sort of, quantify how your pain score is. Because I think that it's very important to have a good communication and a good relationship with your care provider. I think that while we want to help you, we don't have ESP. We don't know how things are going if you're telling us that things are fine. That it's important to say, well, how have you been doing with the last treatment? What side effects were you having? What kinds of problems were you having with your diet in terms of nutrition? How is, how you're doing emotionally or mentally? And of course, how your pain level is. So I think that it is important to, over time, keep a tally of what's going on and how you're feeling, and be able to communicate and express this to your physician effectively. And I think that that is the most important thing to allow you to have effective intervention. I think that for the caregiver, there are a lot of support services out there. I think that we mentioned that, there are wonderful groups, such as the SHARE group that we are working with today, and that there are a lot of support services for your loved ones, but also support services for you. That I think that support that the caregivers give to the patient is very important, but then there is also support that is given to these caregivers and is available to the caregivers. And that can be available through groups, support groups, you know, and it is something that you can investigate further with through the social worker at your doctor's office or through the internet. So I hope that this has been somewhat helpful over the last, you know, 50 minutes of our talk to try to answer and to try to help and see if we could give you extra information or knowledge about expectations and potential side effects and potential interventions. But obviously, 50 minutes is not enough to go through everything. I think that it is important to keep an open dialogue with your doctor, and at the same time, important for you to understand that you as the caregiver is just there for support. You do not have to make any diagnosis. You do not have to, you know, do anything that you are not comfortable with. But it's just being aware that there are services and there are medications and there are things available for your loved one. So with that, I will break and see if there's any questions.
Well, thank you, Dr. Chang. It was a great presentation, and you provided a lot of information and some great statistics and resources, as well as the information from studies, which is really very interesting. So I have several questions here, and we'll get to as many as we can in the next couple of minutes. So the first question is, should patients take anti-nausea pills before or after they feel nauseous?
So I think that that's always a wonderful question. I think that prevention is key. Now, the answer is really depending on when the patient had chemotherapy. That most of the time we encourage our patients to take the medication before the nausea starts, usually for the first few days after the chemotherapy. Then, once we know that the chemotherapy induced nausea vomiting period is over, then we tell them that you can use this as needed.
Great. Do you recommend any supplements in particular?
That is a more controversial question. I think that every physician has their own feeling about supplements, and I try to remain somewhat neutral about this. I myself, I will always, you know, talk to the patient about, you know, working with them regarding the supplements. But again, because there is not much regulation with the supplements, we don't know what interaction the supplements can have with the chemotherapy or with the treatment. A lot of physicians do not want the patients taking supplements during the chemotherapy treatment period. So what I usually tell my patients is that if you were to take a supplement, to try not to take it the day before, the day of, and the day after chemotherapy, to try to prevent or avoid true interactions. But at the same time, if there is a particular supplement they are really interested in using, that I actually will do research for them on that supplement. And believe it or not, the web, there is a lot of information, but at the same time, a lot of wonderful information with not necessarily a lot of data. So I usually review what the data has available, and there are different kinds of websites that will try to give you a neutral and unbiased evaluation of the herbal supplement. So, you know, I will always help the patient with that. With that being said, I don't personally recommend the patient to take too many supplements. I recommend the patient to have a well-rounded diet where they should be able to get the antioxidants, to get the vitamins that they need. But I do recommend vitamin D.
Okay, so other than vitamin D, would the same be true for vitamins and taking additional vitamins in pill form?
I think that, you know, most of the time I would prefer the patient to try to get it through the food, because I truly feel that if something has been processed, it is not going to be absorbed as well through the body. But I will not tell patients not to take a particular vitamin if this truly is something that they want to take and they truly feel will make them feel better. I generally say if the patient really is having trouble having a good diet and maintaining good calorie intake, that they can take a multivitamin.
Okay. So someone commented that many doctors don't address weight concerns and often tell patients to eat what they want during chemotherapy. What are your feelings about this?
That I look at the patient and I look at their concerns. Obviously, our goal is to try to maintain a patient's healthy weight, and we try not to have them have junk food. But for example, if the patient is not eating anything and cannot tolerate anything but ice cream, then obviously I will say, well, then you're going to have ice cream, but hopefully we are going to be able to allow your body to tolerate other foods during your chemotherapy period. But, I know there are some patients that, during the chemotherapy period, they have no preference and they have no desire for any food. And in that particular instance, you are trying to get whatever calories you can in that patient. But preferably, we would try to see if we can have them, have good protein and good calories. And we usually would refer to our nutritionist, Hillary, here at the center.
Great. I know we're at just a minute after 2 o'clock. There are 2 more questions. Would it be okay to just continue for another moment? Okay, great. So someone says that after a half-hour walk that I feel more tired than before the walk. Should I continue?
That I think that it is important to see what is happening, and ask, obviously, to talk to your physician, because they may have to investigate and see, is there any medications that they're on? Is there, any other medical condition that may affect their walking ability? I think that we have, recommended light exercise, and it goes back to what kind of symptoms, what kind of problems they're having after their walk. So even though that's a good question, unfortunately, I cannot answer it in a good way, because you have to know what's happening with the patient more intimately.
Right. Okay. And last question, when you're talking about pain management, how does palliative care fit into that?
I think that we work very closely with palliative care, and we also I think that we should think that the chemotherapy that we are doing is essentially palliative care, and the pain management we're doing is palliative care. That everything we're doing is palliative, because palliative care means something different to different people. But what it, in general means is that you are managing the patient's symptoms, that, it could be in the form of chemotherapy, it could be in the form of radiation therapy, it could be in the form of pain management. So I think that we have, palliative care people that we work with very closely. And at the same time, we have Jim DeLimpio here that does oncology and palliative care. So it is a continuum. And I think that for some people, they feel that, oh, there's a disconnect, because if you're getting chemotherapy, then you can't have palliative care, when that's not true. That chemotherapy is a form of palliative treatment.
That's interesting. Thank you for clearing that up for us. So we're over 2 o'clock. Thank you so much for spending your time with us this afternoon and for preparing a fantastic presentation. Thank you all for participating. If you wouldn't mind just taking a minute to complete our survey, that way we know how we're doing and to continue programs like this. And don't forget to visit us at our website at sharecancersupport.org. And a recording of this will be available online, and everyone will be notified when that's the case. So, Dr. Chang, thank you so very much. We appreciate it.
Thank you for having us.
Thanks.